Of LSTM. And for those of you that don't know me, I'm Laura Dean. I'm a reader here at LSTM in Social Science and Global Health. And our inaugural lecture series is an opportunity for us to recognise and celebrate the work of our new professors. And I'm delighted to welcome Professor Julian Eaton to deliver his lecture today. I've had the pleasure of working with Julian for the last 6 years, with many other colleagues around the globe, to advance the field of mental health and neglected tropical diseases. And throughout this time, I've had a lot of mentorship and guidance from Julian, and it's been a great privilege to learn from his extensive experience working in the field of global mental health. Julian came to LSTM about a year ago as a strategic appointment within the field of global mental health and in the Department of International Public Health. And his appointment marked an important investment for LSTM within global mental health to try and strengthen our impact in this area and recognise the importance of this global field. Julian's appointment strengthens the position of LSTM to galvanise our interdisciplinary partnerships across faculties and departments to support the generation and testing of health systems interventions to address the global mental health burden. At the centre of Julian's work is a vision for equitable partnerships with health systems actors around the globe, and perhaps more importantly, a deep-seated commitment to prioritise the values of those with lived experience. Julian had quite an unusual path to becoming a professor, having spent most of his life working outside of academia. But this is one that I believe made him a unique find for us here, as someone who has a clear understanding of what is needed to achieve impact on a real level within marginalised communities. Julian began his career as a doctor and psychiatrist in the NHS, then moving to work in Nigeria, initially as a volunteer in a small project looking after homeless people with severe mental health conditions like schizophrenia. This led to then joining the Christian Blind Mission's Nigeria office and building their work over almost 20 years, initially as national, then regional and global mental health advisor. And this coincided with the growth of the field of global mental health, and one that Julian has been at the forefront of pushing forward. As we'll hear today, a fertile environment and close interaction between researchers and advocates over the years has led to great advancements in these areas. About 10 years ago, Julian started his PhD at the London School of Hygiene and Tropical Medicine, initially in Togo, where he was living at the time, and then coming back to complete it. We do joke about how Julian would have finished his PhD much sooner, but he was also working full-time in 2 jobs, one as CBM Global's mental health lead, and also as the Chief Operating Officer of the Succeed programme, which looked at strengthening kind of community-based support for people with schizophrenia and was really doing groundbreaking trials in this area. Based on Julian's understandings of mental health as about enabling people to access their rights, based partly on work in the disability sector at CBM, he worked on improving the well-being of people affected by neglected tropical diseases, who are an extremely marginalised group, like the homeless people Julian began his career with in Nigeria. And this was his initial contact with us here at LSTM, through work on mental health stigma and NTDs with myself and David Molyneux. And based on a shared set of values around the use of participatory approaches and disability inclusion, we've had great successes in these areas, working with colleagues in the non-governmental organisation Network on Neglected Tropical Diseases and at the World Health Organization to develop essential care packages for people affected. And so before I hand over to Julian, there's just a few housekeeping issues to cover. There's no fire alarms expected today, so if one goes off, please exit calmly and safely. There are gender-neutral toilets just outside of this room on the right-hand side, and just past the kitchen, and hopefully we'll have an exciting evening hearing from Julian. So welcome, Julian. The floor is yours.
Thank you. Thank you. Thank you very much, Laura. It's such a pleasure to be here, to see so many old friends, my family here, and lots of new colleagues who've been incredibly welcoming over the last year and the time that I've been here. We work in a field that has, by necessity, drawn a huge variety of different capacities together. But I think you're here today with a real common purpose. So although I'm talking about mental health and the way that mental health fits into global international public health, I think it's pertinent to the way that a school like ours thinks about all of its different disciplines. So, do you like my picture? I tried to get old architecture going to new architecture in Liverpool. I think I did quite well, didn't I? So, what am I going to talk about? It sounds like a very grand title, doesn't it? We are living in really quite cataclysmic times for our field, for public health internationally. And there are a number of threads that I'm going to carry through, using mental health as a kind of example of the way that power works at a kind of individual level, as well as in these kind of international relationships that make up our common endeavour to improve public health around the world. When I was 21, halfway through medical school, I took a year out to study sociology, which is a really great opportunity for me to maybe push back against some of the very kind of biomedical approaches that I was being taught in medicine, which is fine, because that's what it is. But it was good for me to have the opportunity to step back and think a little bit more about what I was learning. And at that time, there was a couple of writers that really struck me, and they talked a lot about power. One of them was Michel Foucault, quite famously talked about a history of mental health and how people were thought of very differently at different times in history. And then Frantz Fanon, who was actually came from West Indies, but ended up living in North Africa as a psychiatrist, but thinking a lot about the impact of colonialization on the mental well-being of whole populations. So that was a real important introduction to me to thinking about how power works at those different kinds of levels and the way we relate as health practitioners with people who have mental health problems. Then, when I had qualified as a psychiatrist, I knew I wanted to work in international development, and I went to live in Nigeria. And this is a photo that was taken a few days after we arrived in this small community in the south east of Nigeria, where a family brought their relative who had schizophrenia, and he was chained up, and he'd been chained up for a very long time. And the first thing we did was to saw off the shackles that he'd been wearing for a very long time. You can see how it's affected his skin there. And that, for me, kind of cemented a sense of the purpose that we had being there. It seemed very simple, and it's obviously much more complicated than that, but it was a part of the process of reimagining how we might engage with people who've traditionally been so undervalued in our society. And then this is a stained glass image on the corridor and the stairwell walking up to my office here. And it's the kind of original emblem for the Liverpool School of Tropical Medicine. And it is a ship in full sail. This comes from the website, if I remember it right. A ship in full sail with an endeavour to go to other lands. The sun is rising in the background because it's an exciting new adventure and an ambition to have impact. And there's this rather creepy eye, single eye right in the middle of it. And that's a Greek symbol of healing, apparently. But it kind of slightly completes the circle because Michel Foucault talked about the medical gaze and the way that we have a tendency, when we're looking at the world and at our patients in particular, to read into everything they say what we're kind of expecting to hear. And we define what they've said, which might have been something completely different in the way that fits into the frameworks that we understand. And how that's such a danger, and we need to be very careful when we're doing that across cultures, to really hear what people are saying, rather than what we think that they were supposed to be saying. Refreshingly, the work that we're doing, and it's a 125-year history of this institution, is undergoing quite an examination at the moment about what the meanings behind those early ships that went out to other countries were actually taking, and how the motivation for that relationship with other countries was, and how it's changed over time. It's great The school has recruited a couple of historians who are really helping us to examine that history carefully, to understand it better as we try and forge a better way forward. So here we are, the obligatory childhood photograph. So this is me sitting on the doorstep of our house in Upoto, which is a village in northern Congo, where I was born and raised, with our neighbours. So this is Miriam, who we're still in touch with, and Mama Jennifer's children, she was our neighbour. This is the hospital where I was born, in Pimu, across the river. This is the view from our house. I was born across the river. My parents had to get a pirogue, a dugout canoe, across the river to reach Pimu. And my mum says that I have to say that she had a caesarean section with a local anaesthetic. That was the one thing I was told I had to say today. So this, for me, was a wonderful childhood, which I've cherished and has, of course, informed my subsequent life and thinking and ambitions. If I go on to the next page, I've put a map of what was then Zaire. It became Zaire the year I was born, actually. So this is the village where I was born, near Lisala, in the northern Equateur region, just on the bend of the river. And across the river is Pimu. And when I was 7, I moved to Kinshasa to go to a primary school. But interestingly, this is a picture of the Ebola River, taken by Peter Piot, who later became my boss at the London School of Hygiene and Tropical Medicine. And that's less than 100 kilometres from where I was born. And it was during the time when we were living there that happened. So as you'll hear in this talk, there are lots of connections throughout this story. But the link with the kind of work in tropical medicine started quite early. So moving rapidly on, I came back to the UK when I was 11, and we settled into life here. When I went to medical school in London, I was very engaged in the kind of reaction against the worst of Thatcherism, the kind of end of the end of her time when she was, had a lot of these individualistic type policies. And it was a time of real awakening, I think, around the environment. It wasn't the climate at the time. And a protest movement that really drew on some histories of trespassing and protesting. And that's really where the name of my lecture comes from. A world turned upside down is an idea that came from the diggers and the levellers, a kind of British history of protest. I particularly like this image on the left here. This is Twyford Down, which is one of the really early road protests that I was involved with. It shows what an impact this road was having on the beautiful countryside. But also it was held partly to protest against a criminal justice bill which the government was bringing in to clamp down on protest. Okay? And this is going to come back, something I'll talk about later. It was also fun. We had a lot of fun. And that was important for community and a sense of kind of common purpose. And the other reason I like this picture is because there's a big Union Jill in it. And flags have become very big in the news recently. And this is something that we were putting up around my small town a few weeks ago to make a point about flags. So the picture on the bottom right is a couple of people who were taken to court by McDonald's because they were saying that their food was not healthy, and they were really put through the mill as two people with no money and taken to court by this huge multinational corporation who wanted to silence them. Again, this is something that will come back later, but that was all happening at this time. The police infiltrated their group and ended up actually having a relationship with one of the people, which is just kind of coming out now and is a big scandal. But a lot of that money and pressure was put on by big corporations who were really trying to silence people who actually were making a point about public health. And that's what I'm going to mention in a minute. So apart from partying in London, I also went through medical school, knew that I wanted to work in international development, and so I thought I'd be a GP, and I started GP training. My first attachment was psychiatry, and I absolutely loved it. I loved the engagement with the families. It was intellectually really stimulating, the kind of social ideas that come through psychiatry really strongly, and philosophical ideas, but also the science, and it's an area which I immediately loved and knew I wanted to do. But at the time, there was no such thing as global mental health, and I couldn't really see a career going forward in that area. I'll come back to that in a minute, but I wanted to think a little bit about how mental health is seen in different communities around the world. Now, obviously, this is a huge generalization. It's impossible to think about every different culture, but I think the one thing that can draw together the way that people whose behavior is not socially unacceptable or changes very rapidly, in some cases people might see it as threatening, has always been met on the one hand with compassion and an attempt at care and healing and support, especially by their families who love them, of course, but also by medical professions or traditional healers or imams or priests. This is a very early asylum, essentially, a place where people could go to seek solace in Damascus, and in very common with what was then thought through by actually Quakers in Britain in the 18th century. Again, a beautiful place, lots of asylums in Britain built in very beautiful outside spaces with plenty of green and fresh air. And that was called moral treatment as a way of trying to help people to recover, of course, in the context of not having any effective medications at all. So that's the best of it. But what tends to also happen, and you find very similar things in many cultures, but what tends to also happen is that coercion often comes in. And you have the worst of it, where there's a sense of putting people out of society because they're trouble, because they cause trouble. People don't know what to do with them. And that, I'm not being judgmental, because it's often very difficult to know what to do. But that is what often happens with asylums. They become institutions for coercion and control instead. And that's what happened at the period of time when we started exporting our ideas from Britain to colonies. And this is actually the first such asylum in West Africa, and a whole string of asylums, this one's called a lunatic asylum in Sierra Leone, were built within about 10 or 15 years along the west coast of Africa, because a decision was taken in the Home Office, or the colonial office actually, in this country. And the Sierra Leone Psychiatric Hospital is still there. It's now a modern institution rebuilt by the Islamic Development Bank about 15 years ago, and it's very beautiful. But it's not just the architecture that we exported when we built these asylums. We exported the whole systems of how people thought about mental health and how people should be treated. And one of those, unfortunately, was build big buildings and fill them with all the people you don't know what to do with from your communities. And often that was significantly worse than what was happening already in countries. And it came with that overlay of, we know better than you do about how to do these things, so this is what you should do. And of course, there's a legacy. It is still the case now that in most countries where we're working, especially those that are colonized, which is a very large proportion, almost all the mental health budget is still spent on the big central psychiatric hospitals in the capital cities. Now, most of them are no longer horrible institutions where everyone's chained up, although some of them are. In many cases, they're now acute psychiatric hospitals with busy outpatients departments and lots of professionals doing good work. But there's still no money being spent on decentralized services in the communities where people actually live and where they'd benefit more from that kind of good care. So traditional medicine is still what's used in many countries in the world, and it happens in parallel with these systems that were brought in. People continue to use traditional systems for healing. So in Sierra Leone, the Lunacy Act of 1902, which is the colonial Lunacy Act, is just being repealed and replaced with a much better one now. And in Nigeria, similarly, the Lunacy Ordinance was replaced not that long ago. So that legacy has continued right up till now. And of course, it's high time it changed. So Polly's in the front row here, moved out to Nigeria because, as I said, there was no real career path I could follow. I couldn't do a master's in global mental health at that time. There were no jobs available apart from a few organizations like Médecins Sans Frontières who had roles for kind of counselors and psychologists in emergency settings. There's a little bit of that, but no role where you could really engage in changing systems in the long term, thinking about how to really change systems. And we went out to a project in Nigeria. Nigeria is special in very many ways, and it's very close to my heart. But one of the things that Nigeria had was a very insightful leader at that time in mental health. One of the first psychiatrists in Nigeria was Thomas Adeoye Lambo, who decided to do something different from what he'd inherited in the big psychiatric hospital he was supposed to be running in Abeokuta in southwest Nigeria. And he organized a system that was much more and very deliberately African in the way he thought about it. So he had many, many people being sent to his hospital. He asked all the villages around if they would host them. And they only came as day patients to his hospital. So they didn't lose their social skills. They continued to live in communities the rest of the time. And he was very well recognized for this quite radical approach, which actually, of course, all these years later, we're thinking that we need to do something similar here. And that's an important theme in where we've arrived in global mental health, is learning from our experience in many other countries and applying them often in marginalized communities, in high-income countries. He went on actually to be the deputy director of the WHO after that. So Polly and I went to live in this beautiful place called Amudo, which means Village of Peace in southwest Nigeria, in Abia State. Polly's an occupational therapist, so doing lots of rehabilitation, and I was a psychiatrist. And this is a project, as Laura said, that was looking after people who are homeless, often brought to us chained up, or we identified people on the street, often being treated very, very badly and in a terrible physical condition. They underwent a long period often of good, caring rehabilitation and were taken back to their families and communities as a part of a really nicely thought through rehabilitation process. So this is the last one, I promise. So I also get the chance to embarrass my children. So these two beautiful children are now sitting at the front over there. After 3 years of volunteering at Amudo, I needed to get a job. I thought I'd have to come back to the UK and become a jobbing psychiatrist in the NHS, but we got to know this organisation called CBM. I ended up working with them, and that actually ended up almost 20 years worth of working with CBM in Nigeria and then in Togo before coming back here. That was important for me because I talked about the sociology degree earlier, but CBM is an organisation that's rooted really in a culture of thinking about disability rights and thinking about people in a much more holistic way. And that's one of the things that attracted me about coming to Liverpool here, the tradition of research in this area, in neglected tropical disease, and also in mental well-being and disability that Laura talked about, and there's a group here that does that work, is exactly the kind of work I wanted to do. But CBM was a very important organisation for me in understanding different ways of thinking about mental health and psychosocial disability. Okay, so the corny architecture gags keep coming. So does anyone know where this is, what this is?
Geneva.
It's the WHO in Geneva, yeah. So the title of the lecture is about global health architecture, and I'm going to be talking a little bit about what's changing now. But just as a kind of introduction, the system that we have now of thinking about how countries coordinate in organizing their health, in researching about their health and sharing ideas about what works and how things should be done, really came out of the system that was set up with the UN after the war, and organizations like the WHO that were there with an element of democracy. Countries are supposed to all equally feed into it. The kind of organizing governance structure is supposed to be democratic. And that's supported by systems like human rights, conventions like the Convention on Rights of Persons with Disabilities, which has been very important for us, but a lot of child rights and health rights as well. And then occasional big get-togethers for the world to think about how do we want to move development forward, the Millennium Development Goals and the Sustainable Development Goals. So this system is built on this idea of a type of democracy, of multilateralism, so people working together in different ways. There are the financial systems that sit on top of that with the World Bank and International Monetary Fund to help governments to pay for what they've been advised to do. And the idea of a rules-based order. So we're all in this together. We should follow certain rules. And to a certain extent, there's a degree of kind of sanctions if you don't. So that's how things are supposed to work. Okay? And that is something that I think many of those ideals we aspire to, and it would be nice if it worked well. Okay? But already, before the big crisis that we've had this year, there were some major problems with that. There's a degree to which a sense of some countries didn't feel they had as much voice in that system as others. That actually some countries felt that they were judged more harshly than others. Some countries get to veto decisions and others don't. So there's already a kind of sense of it's not really fair for us. Africa CDC, that's this beautiful building on the right, was founded probably about 6-7 years ago now, really because of the failures with the Ebola outbreak, and the response from the WHO wasn't good enough, it wasn't quick enough and effective enough, and there was a sense that we needed to have different systems, maybe that were a bit more orientated towards certain countries, to regions being able to take more autonomy. Now that's happened already to a certain extent in richer regions. But the Africa CDC has kind of shifted that sense of, well, where do countries get their advice about health from different countries to a certain extent? So some things are already starting to change. And that was the world in which I started my work, first in Nigeria and then in coming back to this country and working in a wider community of people. Important studies in the 90s, global burden of disease studies, recognized how important mental health was in terms of the proportion of all the disability and the shortened life that happened in the world is. But no one was recognizing that or paying sufficient attention to it or investing sufficiently in their health systems. And public health in many other ways had moved forward quite well. You know, HIV was in many ways an amazing success story of people coming together, doing lots of research, investing in what needed to be done. Child mortality had been brought down very substantially by the Sustainable Development Goals, particularly, Millennium Development Goals particularly. And there were some really good examples of what could be done in infectious diseases and other areas. And in mental health, there was none of that. So a group of people coalesced, mainly around Vikram Patel, the person on the left here, and colleagues, to say, why can't we do that for mental health? Why can't we work out what the best evidence is, apply it appropriately in different places, based on these founding public health principles of equity and justice and efficiency and what works and good science. And this is a group of people who came together when we wrote a commission for the Lancet on global mental health. And there's people there. So Grace Gatera is a really important lived experience lead. This is the editor of the Lancet, Richard Horton, and people from WHO and from funders. It was a very exciting time, and I'm just incredibly lucky to have landed in the middle of this when it was happening, honestly, and have been involved in this world of working out the science and what works in different places. But at the moment, only a tiny proportion of people who have even quite disabling mental conditions in the world access the care they need. And a tiny proportion of global funds are allocated to addressing their needs. And that's what we fundamentally wanted to change. Right at the core of our field is this question of culture and context. Can you even have a global field in an area like mental health in the way that you can with maybe more biological diseases? That was the big question. Most of the people who've been interested in international mental health prior to this new application of public health ideas were anthropologists, people who were interested in transcultural ideas, and it was more of an observation and an interesting discussion. And there was, very fertile literature around it and very, very interesting work being done, but less of a urgency about doing something to change how it was. And I think fundamentally that was the first main case that we had to make was, yes, there is enough similar in different countries if we're very thoughtful and careful about culture to be able to make a big difference to lots of people's lives. So Wole Soyinka is Nigeria's Nobel laureate, and he has this great quote, which is, if you're really going to get the best out of a meal, to get the snail, you need to dip your hand right to the bottom of the pot. So we need to invest heavily in understanding cultures if we're going to really understand how we can do good, avoid doing harm, and do things in ways that are culturally sensitive and appropriate. So the ongoing debate, and it is an ongoing debate, is are we risking a kind of cultural appropriation, doing imperialism, doing what was done with those asylums at the turn of the century with our new science that we now think we know better again, and we're pushing that in other countries. That's constantly what we're having to think about. I think it's true of all of our fields, actually, but I think in mental health it's particularly sensitive, and I think we are trying to be very careful about it. So I want to take you through quickly the areas of research that I work in, and then end with some ideas about how we might think about going forwards slightly differently. So first of all, when this global mental health field set up, one of the first things we did was to sit and say, well, what do we need? What are the biggest challenges? What do we need to do? Number one was the tiny proportion of people who receive services, so the treatment gap, which is more than 90% in most low and middle income countries, especially if you say treatment of a decent quality and standard. Okay. So we wanted to make a case for scaling up services and to understand how we could efficiently do that. We knew that you cannot just replicate the way things are done here. We didn't even want to, and there certainly aren't the resources to do that in different contexts. So a lot of this work has been around finding efficient ways of scaling up services, thinking about the human resources and the financing and the systems and where services are delivered. Guided in large part by the WHO, which has been a fantastic partner in all of this work. And I was really privileged to be a part of MHGAP, the big program that they ran from the very beginning, setting up how those services might look. And then did some work around this in Nigeria and in other countries through CBM, including some work on deinstitutionalization. A few years after we'd started, I led this paper in a new Lancet series, trying to measure how we'd done. The sad fact, our findings, and what is still the case now, is that we haven't really had a major impact on that treatment gap, the proportion of people in countries who are receiving services, even though we've gone very far in better understanding, I think, how it should be done. We haven't reached that tipping point of the confidence for investment in a very large scale. The next area is related to thinking about the role of people who are voiceless as we bring services to play. Historically, people with mental health conditions, and actually generally patients in any health system, have never really been asked what they think about the services they should be receiving, especially in the context of mental health. It's pretty unique in most countries where psychiatrists are the only doctors who are routinely encouraged, allowed, enabled to take people's liberties away, and in very, very large numbers in many countries, without enough checks and balances. And that's a problem and something we need to think very, very deeply about. So we've had a number of processes of how to take this forward. And the biggest thing that's really come out of it is we need to privilege and enable the voices of people who lived experience themselves to influence how things are done. Okay, I just wanted to briefly mention this program on the right here, big WHO program, which has been really instrumental in putting tools in the hands of people to judge what their services look like and measure them and try to change them. Okay, so thirdly, this is what Laura talked about earlier, the work in neglected tropical diseases. So a very similar kind of theme to the previous one. This is a group of people very, very marginalized in lots of parts of the world, people with diseases like leprosy or lymphatic filariasis, and something obviously a school like Liverpool has been studying for many, many years. But apart from with the personal experience of lots of clinicians, without any real investment in understanding the science of what we can do to improve the well-being and quality of life of people with neglected tropical diseases, even though we went very far in the more kind of health sciences and treatment of that. So a really collaborative group right across lots of NGOs and science and research have been working very effectively for a number of years now. And I just wanted to illustrate here really how you can move a area of work forward if you collaborate really well across disciplines. So we've done a number of pieces of research in different key gaps that we identified. We published them in a few collections that have really made the case together. WHO has responded very well to that and published a few kind of important guidelines. And hopefully, in a couple of months, in January, we're going to be launching this new essential care package, WHO essential care package for mental health and neglected tropical diseases. But we might run into the same problems that we had with where we are on scaling up mental health services. That we have the science, but is it going to get picked up and applied in countries? And that's where we are. We need to be good at communicating our science and how to make an impact. The final theme to mention, Mohammed and Bixeng are here somewhere, part of a team I work with at London School and will be coming here as well, I hope, on working in outbreaks particularly. How do we make sure that we do a better job of looking at the well-being of people who are affected by outbreaks? I worked a lot in Sierra Leone during the Ebola outbreak in 2014-2015, and we put some of these guidance together. And then actually we translated it into French and we're using it again in the Congo much more recently. And some of that work has also been around making sure excluded people in humanitarian crises can participate in and benefit from the mental well-being work we do in those crises. Okay, so now to the story of where this global health architecture is going in this cataclysmic year we've been living through. So Atul Gawande, at the time, was the person who was overseeing health at USAID. When this memo here, which you can't read very well, but it comes from the Secretary of State in Washington, D.C., saying, stop everything for USAID. We're going to spend 85 days thinking about whether or not the work we do is effective and then review whether or not we should invest in this. His quote here is very powerful. He talks about how it was more than just a cutting of funds. It felt much more brutal than that. Good things, effective things that were being done were stopped immediately, and it was very, very negatively impactful. I want to get the numbers right, but there's a assessment ongoing about how many people have been affected in different ways, and it's estimated that even in 6 months when this work was done, probably at least 80,000 people there were that these cuts contributed to their deaths. This is just in relation to HIV and AIDS. It's very, very dramatic. And the UK halved its international development budget, as did many other European countries. So a real shift in that consensus I was talking about earlier, particularly, of course, when a very key country makes that decision. But what surprised me was, despite the disaster that was for thousands of people losing their jobs, we ceased to be as good at being able to carry out surveillance for early identification of outbreaks. Lots of people working in frontline public health lost their jobs. Jean Kaseya, who's the Director General of Africa CDC, quite quickly said, this is our opportunity to do things differently. And I think it's very important that we carry those two things together. It's not saying it's okay what happened. It's not okay. It shouldn't have happened so brutally. Of course, it's up to people who are giving money generously to decide how they give their money. But it didn't have to be done in that way. But at the same time, sometimes crises usher in change. So John Mahama, who's the president of Ghana, has really led a process which was called the Accra Reset because of a meeting he held in Accra in August 2025, to think about new ways of conceiving of a future international relationship and a future global structure for how public health is done. Of course, financing is a big part of that, but it's not the only part of that. It includes our relationship as a research institute with people doing research in other places. So he talked about, as an old model collapses, we need to be the people who are coming up with the ideas. He's talking about Africa, but there's also a wider group who are thinking about much more broadly globally. So I came to LSTM just approaching a year ago, and actually, although this is a strategic appointment to kind of put mental health as a named entity, there's lots of people doing mental health and wellbeing work. Of course there was. I had the real pleasure of sitting with Jeff Gill and Meg Parks to talk about the oldest research project, ongoing research project anyway, at LSTM, which was the receipt of a lot of Far East prisoners of war back to Liverpool after the Second World War, and the way that they were treated very much had mental health at the heart of it. And this psychiatrist, he was a local psychiatrist, Kamaluddin Khan, was really instrumental in apparently providing very compassionate and thoughtful care to them. Of course, there's also lots of groups of people working here in health systems, in menstrual health, in TB, certainly in disability and NTDs, who've incorporated mental health and well-being already in their work. And I'm really looking forward to working more with them. More recently, I mentioned earlier, I think David's here actually, we've having this thinking a little bit about our colonial past, and I'm really hoping that we can have a little bit of a think about whether there's mental health components to that, and exploring how we might take into account those histories in the way we go forward with our field as well. I took the opportunity a couple of months ago to invite lots of people who work in global mental health across the UK and some international partners, Africa CDC and WHO, and some of the partner hubs that we have in other countries were there also, to think about the UK's contribution to global mental health in the context of the huge cuts that we've all experienced, including in research funding. And really looking forward to using some of the partnership principles that LSTM has been thinking about over the last years to have a different way of engaging in moving forward and how we do things here. I have the advantage that I am not part of a team of 40 people who I'm stressed about trying to keep in jobs. You know, we have an opportunity to do things in a slightly different way. That will mean exciting things like having a master's, but having it based in another country and us contributing to it, not having everyone coming here for a new global mental health master's. There are 6 in this country already, don't need another one. It means some painful decisions probably about more often being part of consortiums where the lead is from a Global South institution, not assuming that a UK institution should be the administrator, coordinator, lead of of a project that is largely being done in other countries. So there will be some difficult decisions, but also it's an exciting opportunity to do things differently and think about things differently. And I'm very pleased to be in an institution that's thought very deeply about those things already. Okay, so I'm probably massively out of time, but I want to go through some ideas of how we might envision a different future with the world turned upside down. So the first one, which I think is the most profound of all, is this idea of acknowledging and celebrating different types of knowledge. We tend to privilege medical knowledge, clinicians, and scientific knowledge, researchers. Now, there's nothing wrong with that, but it's tended to be the case. It sounds bizarre when you say it, that the people who know a lot about their own situation have not really had the adequate opportunity to contribute to these discussions, okay? And that's what really needs to change. And I'm pleased to say we're definitely moving in that direction. You know, at the Wellcome Trust now, every research proposal that is submitted is reviewed by people with lived experience with a lens of whether or not they have contributed to that proposal development. And that's really great. Laura mentioned Succeed. This is the program I was working on for 5 years before I came here, thinking about how people with very severe mental illnesses in their communities could receive support from the kinds of structures that were available in their communities, some traditional, but also local clinics. And this is the team that I was working with on that. And an integral part of the whole way it was done was we had peer researchers. So some of our researchers were people with lived experience. And in the intervention model, peer support. So the kind of support that someone who's been through a journey already of a mental health problem can provide to someone who's just coming at an earlier stage in that process. And it's powerful, and we haven't historically recognized the importance of that kind of peer support. And groups of people affected by all sorts of different health conditions, actually, but in our case, with mental health conditions, have become a really important way of delivering livelihoods projects and all sorts of other ways that people have their lives really changed because of recognizing that unique voice. Secondly, and I've alluded to this already, thinking about the way that we relate as international collaborators in research. This is the slightly creepy I talked about earlier. I think the shift to our new sales going forward maintains that sense of ambition that we want to have an impact on the world, we want to change things. But I think it's been 125 years of learning, and it's great to see the kinds of ideas that are coming forward about new partnerships and collaboration. And there's some work. This is a colleague of mine in Ethiopia, Ababa Avocado, and there's quite a lot of active thinking about what collaboration and partnership means. This is based on Amartya Sen's capability ideas, but there's a lot of good thinking about this, and we love a nice framework, don't we? Especially if it goes in a big circle and reinforces itself. But fundamentally, it comes down to human values of trust and of respect and of mutual appreciation of what we can bring to collaborations. That's the fundamentals of it. Thirdly, we live in a world where, certainly for mental health, the environment in which people live is such an important part of their well-being. We've always liked to think within the medical profession and within people who work in public health that we have solutions, but actually the world in which people live has a huge impact on their mental well-being. We know that. And increasingly, that world is defined by commerce and people making profits out of products that are quite bad for public health. We have always been, as a public health community, very bad at conveying what we know about, let's say, the impact of smoking on health, or of alcohol on health, or of climate change on health, in a timely way that saves the millions of lives or improves lives in a way they could. Usually there's a 20, 30, sometimes 40-year lag from when pretty incontrovertible, very good evidence exists that you can't deny before it starts filtering through into policy and in restricting the activities of companies. This advert for Primus, which is the kind of classic beer of Congo, says to love the Congo is to love Primus. Really powerful advertising. That's your national identity is associated with this beer brand. The scandal, of course, is that it takes even longer for us to be able to have an impact on the types of policies that exist to protect people's public health in poor countries, because systems of managing public health, systems of restricting advertising, for example, often the governance isn't so strong on them, and people suffer for longer and are subject to greater abuse from these forces than they need to be. I have put Instagram here just because in the area of mental health, these of course are mental health, these are about addiction. These, the whole world of social media is a huge experiment that's being held on us. And quite a lot is already known about the impact it's having, especially, for example, Instagram, the reason I put it there, on young women with an app that's largely about comparing yourself to other people and thinking you look terrible and everyone else looks great and they're thinking the same about you, So there's definitely some evidence that it's doing harm, but have we got the means, the levers to restrict the harm that's being done? No, not at all. And this has been the case with these others as well. So we need to be better at controlling these. And this idea of commercial determinants of health, I think, is a really powerful idea. There's a fantastic commission last year about it, and I think it's worth understanding how we can be better at that kind of political side of the work we do. When we lived in Togo, Marlborough wrote to the Togolese government and said, you want to put these pictures on your cigarette packets warning people about the dangers of smoking, but we'll sue you, and we have more money than your health department does. So you have to, and they also said that in Australia, we did the same thing and we won, which was an outright lie. They lost in Australia when they tried to sue the Australian government. But this is what especially small and not wealthy governments have to put up with in terms of the power of these big companies. Of course, Shell in Nigeria and Ken Saro-Wiwa, there's often this collusion between government and the police, for example, and these big companies. I gave the example earlier of the people who are standing up to McDonald's in this country, and they were spied on by ex-police officers paid by McDonald's who had access to police information, which they used. So in public health, we need to not be naive to the money behind the same issues we're dealing with, but that can often have much more effective ways of conveying it to the public than we have. So that's the third way we need to turn the world upside down, is to take seriously the impact of business, which of course can be good. I'm not suggesting business is evil at all, but to recognise, to be really crystal clear about the negative impacts of certain types of industry, and being very clear about what needs to be done. And obviously, the biggest of those, the biggest threat to our public health is the impact that our lives and business is having on our planet and climate change. So the final reset is around changing the way we relate to our planet. We have used up the resources of the planet much more quickly than it's being replenished, and we're continuing to do that at an accelerating rate. The Lancet Commission on Commercial Determinants, which I talked about earlier, was followed quite recently, just a couple of weeks ago, by a commission on a countdown that keeps an eye on where we are on public health science and the climate. And most of the promises made by governments 5-10 years ago are now being abandoned. Many governments are going backwards in terms of political support for our most important issue in public health. In the small community where Polly and I lived in Nigeria when we first arrived, every day we used to see these lorries driving up the roads full of logs that were being taken out of the forest. And of course, people were paid to let their logs go. But the long-term impact on those communities who really rely on everything the forest can provide wasn't really part of that calculation. It goes beyond that. There's an idea in the kind of emerging science of mental health and climate change called solastalgia, which is the idea of how you feel when your traditional relationship with the environment around you is suddenly changed, is ripped away from you. And that's happening with lots of indigenous communities in forests or in very cold parts of the world, or people who live on the edge of deserts. Our emotions are closely related to the environment around us, and that's being increasingly well recognized. We have a real issue of pollution affecting children's brains in a way that we don't really know what the long-term impact's going to be, but the evidence is getting much stronger in that as well. So we need to be standing up for our planet with our science and our voices to try to do that. So going right back to where we started, the UK is one of the most hostile places to be a climate protester. You're much more likely to be arrested here, and you're more likely to go to prison than in many other countries. Brazil is a very dangerous place to be a protester as well, and in fact they have a very high number of people who are killed for trying to protect the forest. But in this country, there are many doctors included among the people who are involved in protesting about climate and who've ended up in prison because of it. And we need to change that. We need to have a situation where the science, which is incontrovertible, is what drives government direction, not squashing that science in the name of growth and other priorities. So that's where I'm finishing. Sorry, it's a bit negative. We have the opportunity to turn things around. I think we've had some great wins in public health, but we're also going through, I think, a really fundamentally challenging time. We're going to have to deal with fewer resources for our research. All of us are talking about how we haven't got any money anymore to do anything. But I do think that's also a creative time. And it's particularly a creative time when we need to let go of some of the historical relationships we've had in a global endeavour. Thank you.
Thank you, Julian, for a really thought-provoking hour. We've got about 5-10 minutes for some questions. If you have a question in the room, raise your hand. Someone will arrive at you with a microphone, I believe. And if you have questions online, if you pop them in the chat, somebody is monitoring that. So, yeah, over to yourselves. I think Fuad has a question and Charlotte and one here as well. Feel free to sit or stand, whatever you want.
Disappear behind the front row.
You hear me?
Yeah.
Yeah.
You hear me?
Yeah.
So thank you, Julian. Very, very insightful and amazing presentation and thoughts and ideas. I have two short comments, if you allow me, and one short question. The one eye symbol, it's not a very creepy one actually, because it's a symbol in many, many cultures. You know, it's a Horus eye, from old Egyptian eye, it means for protection.
Okay.
It's mainly in many other cultures. So it's an eye of protection, and you're still seeing this eye.
Yeah.
The second one is about this, the asylum, the mental health asylum in Damascus. You know, I'm from Syria, and I know that place very, very well. I was a guide tour for having like people to see that.
Now you're going to tell me what I got wrong about it.
Yeah, we'll go one day there. So, and interesting that this one is back to 11th and 12th century, where they treated people with the three elements at that time:
You have to go quickly.
water, music, and light.
Yes.
So it's very interesting experience by itself. My question is about the issue of this balance between in theme 2, you mentioned about power, human rights, and for me, you know, how you think this, universally recognized principles, human rights principle, could be sometimes in a conflict with the cultural sensitive issues.
Yes.
And that actually happened in many, many cases and places where I visited. So this is an issue to how to consider that in your research. Thank you.
Thank you, Fouad. We'll take a couple of questions together and then and some responses just in the interests of time.
Yeah.
Hi there, Charlotte Hemingway. I'd love to hear if you've had any experiences or views on using creative methods to enable patient voice. So we're thinking theatre, storytelling, creative writing, that kind of thing.
And then the last question.
Thank you, Julian. My name is Mohammed. I am a psychiatrist from Iraq. I've been here working in the NHS for 1 year on a fellowship. So I've got two questions. I've got 10 years of experience working with the MSF, with the WHO back home, because it's a post-conflict area. One of the major challenges we had back home is, as a humanitarian worker, as a mental health advocate, how we can approach the politicians, the policymakers, the authorities that... whether we agree or not is very part of the problem. The second thing is how to prioritize the needs for an area of like Middle East, a very complex area. And I know there are some kind of guidelines, but we find it very difficult to pinpoint what's the priority, what's doable, what's applicable, and with the available resources that we can tackle that. Thank you.
Should.
Over to you, Julian, I think.
Okay, and then, okay, so, I mean, you've asked me questions that are impossible to answer in 5 minutes, particularly Fouad's one. I mean, I talked about the way that the UN and those kind of global governance systems were set up with very high-minded principles around equity, but there's always a slight suspicion that they're actually quite Western. Human rights is a classic example of that. That fundamentally, I think, across cultures, you will see the same principles of inherent value of people, you know, protecting vulnerable people. It's not just about most powerful people getting their way all the time, but language of the way human rights has often been brought to countries hasn't necessarily been very sensitive and not listening to people in those countries. So that has often been a problem, I think. I know that some very sensitive and careful, thoughtful work has been done, for example, with people who are wanting to work to protect the rights of gay people in countries, but it's illegal to do so. And thinking carefully about how you might do that is part of a profession of thinking about international relationships in a subtle way. but it is a real issue that it hasn't always been done very well. And the same thing goes for mental health. We might actually believe that a certain intervention is probably helpful across cultures. You have to be very thoughtful about how you engage with local communities to really make sure of that, and maybe it might just be how the same thing is done, not that it's not done at all. In relation to creative methods, absolutely, especially in research, if you want to engage people and learn their ideas, it's usually not very helpful presenting them with a questionnaire. Having ways that enable people to comfortably communicate sometimes quite complex ideas is very helpful and effective. I think photo voice is something that's been used here quite a lot, but also as kind of therapeutic methods. Yes, absolutely. The problem is that no one's invested heavily in evaluating them, so it tends to be harder in a kind of open market of what's worth investing in and efficient, and because there's not enough research done. But that's a gap. That it's not that we. It's a lack of knowledge rather than knowing it doesn't work. That's the issue. Yeah, but it's certainly appreciated by people, often more than very, especially young people, than very traditional treatments. Your question about how we engage with politicians is the crux of what I was saying. How do we translate science to impact? I think the thing about mental health is it actually touches almost everyone. The biggest impact we've had in many places is when there's been a champion at that high level of politics because their sister has depression or their mum died of dementia, or all these different personal connections that people have. What's a bit different from other health conditions is they often can't say that in public. So you have to have quiet conversations with people who actually sympathise with what you're doing, but because of stigma associated with mental health, cannot say openly that I'm a champion for mental health. Now, of course, you have some remarkable people who are. But I think engaging with people on a personal level is always going to have to sit alongside presenting good, hard economic evidence about the investment case for mental health. You always have to have that personal side as well.
Brilliant. Thank you so much, Julian. There isn't questions from online, but just to tell you that there's attendees from 45 different countries, so we really have gone global, and lots of well wishes for you. I think everybody's excited to have you here with us at LSTM, and we've had a really interesting evening, so thank you very, very much.
Can I just say one more thing?
Yes.
I'm sorry, I was meaning to say that before we got into questions, but I just wanted to use this opportunity to say thank you myself. So obviously this is where I put my foot in it by not mentioning someone who would be important in my life. Okay, so with that proviso, my parents are online. They would have loved to be there, they couldn't be, but as you saw from the beginning, a lot of where I'm from is about their commitment to justice and to changing things and to improving the world in places where it wasn't familiar with them, where they grew up. There's lots of people at CBM who really nurtured me and believed in mental health at a time when not many NGOs did. And really, I'm actually going to avoid mentioning names because there's so many special names. I'll be here all day. But lots of people at CBM, you know who you are. I really benefit from that. People in that picture in global mental health, lots of mentors who've really, again, been part of a journey that really supported me when I was just a person in a village who wrote an email to someone at King's College and said, "What do you think I should do about this?" And they replied very generously. And you know who you are as well. There's a whole long list of colleagues from Nigeria and Togo who I worked with very closely, and many of whom I enjoy ongoing collaborative relationships with, and at the Centre for Global Mental Health at London School, as well as colleagues, some of whom are here, and at the WHO, who've been really supportive of mental health on a exciting collaboration between NGOs and research. I want to list a whole load of people. I'm not going to mention anyone so I don't get it wrong. But thank you. My family are here, who've been very patient, being away a lot.
Thank you, Julian. And if just a few things to say, if you've enjoyed this inaugural lecture, there's a whole series of them. The next one will be on the 14th of January from Tom Fletcher. And there is a, should the screen change? I was told the screen would change and there would be a slide here. No, go to the website and there'll be more information there if you're interested in attending them. There are drinks outside, so please do stay around and chat more to Julian and each other. And hopefully everyone is now an advocate for global mental health and wants to learn more. So thank you very much.